Good afternoon, team. Otieno, confirm if you can hear me.
Yes, Ngoga can hear you.
All right, thank you. So, good afternoon once more. I can see we are still very few. We are about 26 participants so far. I'm requesting that we give ourselves some few minutes. We can purpose to start at 10 minutes past 2. Meanwhile, I'm requesting that we can reach out to our other colleagues who are meant to attend this training so that we can begin together. So let's start at 10 past 2. Thank you. All right. So in the interest of time, I think we can we can begin our training. So once more, good afternoon. My name is Franklin Songok. I work at NASCOP SI, and allow me to take this opportunity to recognize the presence of all the participants, the county teams, facility teams, the sub-county teams who've been able to join so far, service delivery partners, and everyone else who is in this call. So this is one of the many series that we planned. Just give me a second. A minute, sorry. Oh, sorry. I was consulting. First, I need to just quickly check how many we are. We're about 60. I need some guidance here. Otieno, we are about 60, and I know we're expecting over 100 participants. What would be your suggestion? Do we begin or we still give ourselves some time? Sorry, Otieno?
Yeah, so Gok, I think it would have been better if we could start maybe if we get a minimum of 100, given that the topic is we are going to talk about a new module. So it would be good to have many people participating. So maybe we can give ourselves a bit of time until we get to maybe 100. Then we begin. That would be my suggestion.
So I don't know, are we then mobilizing our other colleagues to join? Because again, we may end up waiting and we may not attain the 100 the 100 minimum number of participants. I don't know whether we have people who are mobilizing, of course, apart from those who have already joined. Do we have other people wanting to mobilize as we wait? Makoa Harness, like, you have a suggestion? Your hand is up.
Makoha, you can unmute. I've given you the mic.
Okay. In the interest of time, I think we are at 102. We had purpose to attain 100 participants before we begin, and I think we have reached the 100 mark. So we can, I guess we can begin at this point. So again, let me take this opportunity to welcome all of us into this training. Like I said earlier, for those who joined us earlier on, my name is Franklin Songok. I work at NASCOP, and I want to take this opportunity to recognize everyone who's been able to join us so far. I know participation is drawn from the county teams, sub-county teams, the facility teams, service delivery partners, and also partners who support the national program at the national level. So I want to request any volunteer to pray for us. I know, Otieno, there are only 3 of us who have the mic. I don't know who else can be.
Anyone can just raise up their hands, then they get the mic.
Then we begin, yeah, sure. So anyone, please kindly raise your hand. We'll give you the mic to start us off with a word of prayer. Any volunteer, just raise your hand. We'll give you the mic. Wow, no one is touched this afternoon to pray. I'm not seeing any hand up. Thank you very much, Faith. Otieno, allow Faith to pray.
Good afternoon. Let's pray. Thank you, dear Heavenly Father, for this meeting. Thank you for gathering us together. We pray that even as we go through the training, that you may help us to retain what is shared, and that you may just hold the technology so that we are able to go through the entire session. In Jesus' name I do pray. Amen.
All right. Thank you very much, Faith. I want us to begin, and at this point, I know I may not want to really take much time in terms of allowing some of our colleagues to speak because of time. Just like I'd said earlier, I recognize the presence of all of us and the support of all of us. So I want to quickly just take you through the objectives of our training. One is that we intend to, like Otieno had mentioned earlier, today we'll be discussing or we'll be training you on the processes on how to create orders, and in this case we'll be talking about the lab orders and the drug orders, and I think other various services, just in case time allows. Then we'll also be able to do some bit of an illustration, just looking at the value proposition for the community pharmacy module within the EMR, and also demonstrate the workflow in as far as the community pharmacy module is concerned within KenyaEMR. So these are new features, or these are new modules that features and module that will be able to take you through, and that's the reason why we really wanted most of our participants to join in, or most of our colleagues at the facility level, county at the sub-county level to join in, because we'll be discussing something new today, and we would really wish that we build the capacity of everyone else to be able to utilize and of course scale and advocate for use of these features and of course the modules. So that is basically more like the main topics that we'll be discussing. So Otieno will take us through the first part of the presentation, just to take us through a slide deck on an introduction to the community pharmacy module within KenyaEMR, and of course touch on some of the value propositions, what are the advantages, how are we going to use it, and then Rajab will now do the demo, more basically just focusing on the orders workflow and also the community pharmacy workflow in KenyaEMR. So I think those are the two items on the table, and that's what we'll be discussing today. And I would request, in case you have any questions, utilize the chat. Kindly ask the questions on the chat. But of course, before the end of our training, we'll also be able to give you an opportunity to just verbalize or any of the questions that you have, or any bits that probably were not clear, and you would want a facilitator to probably just provide some more context in any of the areas that have been clear. So at this point, allow me to welcome Bernard Otieno, to take us through the first part. Otieno, once you're done, you can usher in Raja. Then after that, we have a plenary. I'll come in to just take up the plenary session. So Otieno, over to you. Thank you, and you're most welcome.
Thank you, Songok. Please confirm that the screen is visible from your end.
Yes, it is. Otieno, you can proceed, and I can also hear you loud and clear. Proceed.
All right. So thank you very much, and welcome everyone to today's session, where we are intending to touch base on a new module in KenyaEMR3.x. This is a community pharmacy model, just like Songok has mentioned, and I just want to take you through some of the highlights of this module before we actually go through the demo, the actual training, which will be led by my colleague Songok. Yeah, so my name is Bernard Otieno from Palladium, and I'm glad to take you through this session. So we'll be looking at the introduction to the community pharmacy model. Why is it important, and what are some of the value that can be derived from it, and how are who or what does the model look like, and who stands to benefit while using this particular model. Yeah, so as I said, this model is a voluntary community pharmacy that is based on differentiated care model, which is targeted towards established client, or if you want, you can talk about stable clients, where they're able to access or pick their medication from their convenient pharmacies within their locale. So they don't really have to get all the way to the facility to get their medication. And one thing about it is that for the participating pharmacies, they'll still be able to receive their supplies at very nominal rates from the government, just as usual. So the next question now is about why CPM? Why this model? So one of the important things about this model is that it brings a lot of convenience to patients, especially the flexibility where stable clients can choose what time they want to go and take their drugs, which pharmacy within their locality they want to visit and take their drugs. So it creates a lot of convenience, and they give the patient the independence of choice in terms of where they want to receive their medication. It reduces a lot of travel cost for patients, especially those who maybe their facilities could be a bit far. So they'll benefit from the reduced cost of travel because they don't need to really travel. They can even go on foot to go and have their medication from the nearby pharmacy. Again, also in terms of stigma that mostly associated with visiting some of the major facilities or the hub facilities, they may choose not to go, or so that they can focus on getting their drugs locally. And again, also for the facility, it is beneficial because if we don't have so many patients lining up at the pharmacy, then we'll talk about the reduced workload at the facility, so that our providers can focus more on attending to clients. Again, also the waiting time because of the queues is reduced substantially if the facility adopts this model. so that you don't have so many patients waiting for drug pickup at the pharmacy. Yeah, so how does this model benefit our patients? Yeah, so one, this is a model that is patient-centered because now it takes care of the patient's ability to pick drugs from wherever they want at their local area. And again, also because of that, because of such conveniences, we believe that the adherence rates will be high because some patients miss their appointment simply because they fear of the waiting time at the facility. So we believe that if a patient can be able to take this at their local pharmacies, then they'll be able to adhere to their drug pickup time, as well as ensure that they have the necessary drugs to ensure that they are able to suppress. And that way, we believe that they'll be able to, their state of health will improve. And we talked about the cost saving due to now decreased travel, and of course decreased waiting time at the facility, because now if many patients are going to take their drugs at their local pharmacies, then at the facility we believe that the queue will be shorter, and that will reduce on the on the waiting time. We can talk about the flexibility in the drug pickup time. Again, I think I've talked about that. And of course, that convenience of picking your drugs closer to home. I've talked about the reduced stigma as well. So by adopting this model, we believe that different actors will benefit in different ways. And I think for the facility, one of the ways they'll benefit more, especially for the public facility, we will be having the reduced caseload at the hub pharmacies. And this will release the hands of the provider to ensure that now they can provide better care and they'll be able to interact more with their patients. And that will improve the quality of care that the patients will get in these particular facilities. Again, also the cost saving in terms of human resource. If we have less patients lining up at the pharmacy or requiring the pharmacy services, then you may find that in some facilities they can even reduce the number of personnel manning the pharmacy, because now we'll be having fewer patients lining up for pharmaceutical services. Then we also we can talk about improved suppression, viral suppression, because now the patient will not be missing their drugs. They'll be able to get their drugs on time, and that will eventually could potentially lead to reduced new infections if better percentage of our patients are able to virally suppress. Then we believe that U is equal to U may prevail. Again, also to the private sector, especially the private pharmacies, they will be able to experience increased income because now they'll be having more people going to get services from those private pharmacies. And again, also in terms of capacity by the private sector to provide HIV management and treatment. And this is something that not most of the private pharmacies have been doing. But I think going through this model, this model, I mean, these pharmacies will be able now to stock the ART drugs and also be able to dispense, and that brings a whole new dimension in terms of the services that these local pharmacies provide. Again, also it will lead to increased access to ART. Yeah, by this particular patient. So we can look at how this looks like. So the community pharmacy model takes the hub and spoke kind of approach, where we have a pharmacy, a health facility, which acts as the hub, and then it can be linked to several pharmacies within the catchment, so that you'll find that maybe in one facility you can have like maybe 4 or 5 or 6 pharmacies that are linked to it for the purposes of the CPM. And these eligible public and private pharmacies will be acting as spokes to this particular facility. And as I said earlier, participating spoke pharmacies still will benefit from the supplies by the government at the nominal fee. And looking at the eligibility for CPM by patients. So there are two major eligibility criteria for a patient. One, the patient has to be established. That means they have to be stable and eligible for DSD. So the patient has to be an established one. And again, that patient must be comfortable to receive some of these services from the local pharmacy. So it is voluntary. It's not like patients will be pushed to go this route, but I think through proper sensitization, most patients may find this like a good idea and get into that particular arrangement. Again, for the spoke pharmacies, the minimum eligibility criteria is one, they have to be duly registered pharmacies in Kenya. And again, also they have to be willing to participate in the CPM model. And again, also there's a requirement that they have to be linked to the nearest hub. So they have to identify a hub that by which they'll be able to be linked so that they can receive referrals from that particular facility. Now, for the hub facilities, currently in phase 1 of this, the requirement is that they must be having a cloud-based EMR implementation in order to achieve this particular arrangement. But again, NASCOP will be able to provide further guidance on the eligibility and also the readiness of the hub facilities. So NASCOP will be able to look at different facilities, look at different parameters and guide in terms of whether that facility can act as a hub and get into the CPM arrangement or not. Okay, yeah, so that's pretty much the introduction to the community pharmacy model. So at this point, I just want to pass the mic over to my colleague Rajab, now to just take us through A to Z of how do we enroll patients into this particular regiment, how do we link the local pharmacies, and how do patients move from these hub facilities to the spokes, and that particular referral process. Yeah, so I want to leave it at that and usher in my colleague Rajab to take us through that. Rajab, if you are ready.
Thank you, Otieno, and thank you for the comprehensive overview of the community pharmacy. So if you'll allow me to share my screen. So Otieno, confirm if you can see my screen.
Yes, I can see.
Okay, thank you, Otieno. So basically, as explained by Otieno, the community pharmacy model is to basically allow the sites or allow patients to pick drugs from the nearest point of preference, not to really force them to come to the site. So one of the things that has been done with this particular module, first of all, is to do some mode of restrictions, so that the spoke facility should not be able to access data of the other patients in the main facility. So this is something that was put into consideration in terms of security-wise and the Data Protection Act. So if you'll allow me, I'd like to take you through now the walkthrough of the community pharmacy. So allow me to log into the hub facility, which is basically the main facility. So I'll log into my main facility. So once you log into your main facility, you should be able to see on the left navigation panel, whereby we have the community pharmacy tab at the bottom. So here, this is whereby we should be able to now assign both users and patient to a particular spoke facility for us to be able to see these patients in the spoke facilities. So allow me to just showcase this. So once I click on the community pharmacy, I should be able to see a list of my spoke facilities that have been enrolled or rather registered in this facility. So for instance, I see this site I have added Sarara, Naifam, and Belladonna. So now for me to be able to add users and assign patients to these particular facilities, I'll just navigate and click on one of my spoke facilities. For example, I can click on Sarara Chemist. So once I click on Sarara Chemist, I should have two tabs. One is for assigned patients and the other one is for assigned users. So on this tab, basically, one should be able to add patients to a particular spoke facility, or even remove or rather revoke patients from being accessing drugs from that particular facility. So here on this particular page for assigning patients, on the far right hand side, there's that icon, which is labeled assign patient. If I click on this icon, it should be able to prompt me to open another dialog box whereby I should be able to search for patients within my facility. So for example, I can just search for one of the patients. I can just say maybe CPM2 test. Click on my patient and say submit. So basically you will see that my patient has been assigned to this particular spoke facility. Also, for me to be able to add maybe a provider or rather a pharmacist or a pharmtech, there's this tab labeled assign users, which you'll also make use of to add users for them to be able to access these clients from those particular spokes. So if I click on assign user, the same dialog box will appear, and I'll need to search, for example, for any user in my facilities. For example, I can see this user is available. I'll click on that user and also submit. So once I submit, my user should be eligible to access patient records from that particular spoke facility. So that's practically that's how we assign patients and we assign users to the spoke facilities. If now you'll allow me now to walk you through the journey of how we get to enroll a patient in the community pharmacy model, and how we get to do the ordering, and how we get to dispense drugs for these patients in the spoke facilities. So for this particular case, I'll just navigate to my search icon, which is usually located at the top. I will search for a patient. For example, I can call on my CPM2 client and open this patient. So once you're on the patient chart, I should be able to navigate to the care panel. This is whereby we always do enrollments for our patients. So I will click on care panel. Once you're on care panel, you should be able to navigate to the program enrollment bit, whereby we have the program enrollments available for us to enroll our client. So currently, as you can see from my program enrollment, I'm missing the CPM enrollment. The reason as to why I'm missing it is, one, my client currently does not fit the eligibility criteria to be enrolled for the CPM. And as my colleague had showcased earlier on during the demos, is for one to be eligible for this particular model, one, you need to be enrolled in HIV, and not just that, but you need to be an established client. So for you to be an established client, one of the things that is being considered is that you need to be on ART for a period of at least 6 months. So that's one thing that we will consider. And then next is the consenting bit. So kindly allow me to enroll my client on HIV. So I'll need to backdate this so that I get the 6 months threshold for my client to qualify to be established. So I'll backdate back to January. navigate, just check in my client first. So I should be able to now enroll my client on HIV. Say it's a new client. Just pick any entry point. I'll give my client a CCC number. And say it was test and treat. Then this facility, even on for staging. Just document this quickly so that we can proceed. So once I'm done with that, I should be able to enroll. So once I enroll my client on HIV and he or she meets actually the threshold for being on active for more than 6 months, you should be able to see the CPM now appearing here. And now my client is eligible to be enrolled for CPM. So allow me to check out and check in using today's date so that we can enroll our client on CPM. So I'll check in now using today's date. Your location, have my client and try it, all that. So now from here, I should be able to now enroll my client on CPM. So I'll this is the form, the CPM enrollment form. Basically, this is how it looks like. So we have these questions here, which the client needs to fulfill for them to be enrolled into CPM. So first of all, my client needs to be enrolled for more than at least 6 months. If I put 1, you will see an alert telling you that the ROC is not eligible for CPM program. One because they haven't met the threshold to becoming an established client. So allow me to have it at 6 months, and then to be treatment, I just say no. Just say yes, and then I'll just say that my client is on LDL. The next is the declaration bit, basically to get consent from the client if they are willing to be enrolled for CPM. So I'll say yes. Once I say yes, which will ask me if I'm okay to give him the CPM. And then the consenting bit, once I'm done, I'll click save and close. So with this, if I navigate to my panel summary, I should be able to see my client has been enrolled on CPM. And so practically now my client is enrolled on CPM, and he or she is ready to be given the CPM programs. So from here, now how do we do the ordering of drugs for this client who's on CPM? So once you've enrolled your client on CPM, if you click on the form tab on the right, you have the clinical forms. Once I click here, I should be able to see a CPM referral form here. So once I click on the CPM referral form, basically I will use this form to now order for drugs and refer my client to the specific pickup point where they feel comfortable. So I will proceed and click on next. So here I'll need to give the name of the pharmacy that the client is willing, or rather prefers to pick drug from. So I'll just use, for example, Sarara Chemist. So I'll click on it. Contact details of that particular pharmacy, just give in the number 23456. Then the current regimen that the client is on. So I'll just pick, for example, TLD. Then I will also issue an appointment for the date that the client is supposed to pick drugs from that facility. So I'll click on add appointment. So under add appointment, basically the location will be Mary. This is where I'm doing the appointment from. Then I'll say the service is a drug refill. Then the appointment type should be scheduled. Then I'll just pick all day. I don't want to specify a specific time that the client should go and pick drugs. So I'll just say all day. And then I'll navigate here. Sorry, I should be able to give a date for the drug pickup. Let me just say maybe a month from today or so. I can just have 10th. And then let me just have today's date so that we should be able to dispense. Today is 9. Today is 5th, sorry. Just have it as 5th of September. This date. Then I'll proceed, select the status to be scheduled, and proceed to save and close. So I've already done now the appointment. Now next, I'll have to do now the drug order for this particular client. So I'll click on the drug order button. I will search for the drugs that this client is on. Tenofovir. I'll look for that drug. TLD. It's this one, 300, 350, yes. So I'll click on order form on this particular drug. Then from there, I should be able to now continue with my prescription. Just say, give this drug for 90 days. Give my client its one tablet. Then it is 90 tablets. The route is oral. Frequency once daily. Able to proceed, and then maybe just give an indication for that drug. I'll say it's an ART drug. And once I'm done, I click on save order. Sorry for that. I need to relaunch my workspace. On time. 3 p.m. just to okay. So let me just fill it quickly. XTLD, just do it quickly. I had already done appointment. So I was on drug order. Tenofovir 300. Is that drug? Yeah. Order form. Done for 90 tablets. So it was oral. Frequency was once daily. Duration was 90 days. Issue 90 tablets. And the indication was RT. Save order. Then I'll just sign and close. So once I'm done with that, as you can see, your order has been placed successfully. Then I will navigate to say the person doing this, the CADA, just pick it's a clinical officer, and then click on save and close. So once I'm done with this, so basically that's how we do the ordering for the drug using the CPM component. So the other bit is that for this particular client, once they get to the Spoke facility, there's another form that should be filled from the other end, which basically is now the CPM screening form. Just want to highlight this form. So basically this form, what entails in this form is we'll just need to do, just need to pick some of the conditions that maybe the client might be having. So one of the question is, if the client has missed drugs for more than 7 days, you need to indicate that. Then you need to screen for TB as well. You need to document that, and it will pre-populate for you. Then from that, you need to document any signs of jaundice, if there's any persistence in headache, if the client has been in contact with anyone with TB for the last 12 months. And then any medication taken before the visit, if yes, you'll need to give a history of that medication. If no, she'll be able to proceed. Use of herbal remedies as well, you need to document if yes or no. And then if the patient had actually skipped taking drugs for any particular day, you also need to document that. So once you're done, click on next. So if you have any notes to document here, the pharmacist can just document there and save the form. So basically, what we have done here now is we've managed to enroll a client on CPM. We've managed to map our client to that specific spoke, spoke location where they'll pick the drug. And we've been able to schedule an appointment, and we've also been able to order for drugs for our particular patient. So now what I want us to do now is I want us to log out of the spoke facility and now log in into from our facility and log in into our spoke facility. So just allow me to log out and log in now into our spoke facility. So I'll speak that username and password. So basically, if you can see now, I'm not in Nyeri. I'm now logging into Sarara Chemist, which is basically my spoke site. So one thing I want us to note is that if I click on the search button and search, so I can only search for client who have been mapped to this spoke facility. So for example, I'll look for my CPM to client who's here. So, and I should be able to access records for this particular patient. And once I'm here, I can be able to see the medications which have been done. For example, I can see today, there's one that has been recommended. If the client is on any allergy, also the pharmacist or maybe the pharmtech can be able to see from here if the client is on has any allergies. If the client has any pre-existing conditions that maybe might affect them being issued a particular drug, it will the pharmacist will be able to pick that here at a glance. So now for this pharmacist to be able to now dispense drugs to this client, I will navigate now to my dispensing, click on the modules, come to dispensing app. And once I'm here, I should be able to dispense drug for only those clients who have been mapped to my particular spoke facility. As you can see, only these two clients are currently have been mapped here and do have an active prescription. Then from here, I can proceed and click on dispense, and it should allow me to dispense drug for my client and proceed. Yeah. So I'd like to pause there and open it up to the team. So maybe I'll hand it over back to you, Otieno.
Yeah. Thank you very much, Rajab, for that. And I think that has been very well done. So maybe I should just give the mic back to Songok, and maybe Songok, you coordinate us in the Q&A as we proceed. So back to you, Songok.
All right. Thank you very much, Otieno and Raja, for the demo. I think we all have appreciated the value for introducing this particular module within KenyaEMR. I think based on what Otieno has taken us through, just in form of a quick recap. All of us now understand that the community pharmacy model basically is more like a voluntary community pharmacy-based differentiated care. So meaning there's also criteria of enrolling our clients into this particular model, because we know clients who are not on BSD basically may require other services within the facility. So the requirement is you may need them to come to the facility so that they can also benefit from other services. But if it's just a matter of just coming to pick drugs, then this model would really help in terms of reducing the workload, reducing the time spent at the facility, cutting costs in terms of transport, reducing the traffic within the facility, and all that stuff. So I think this really comes in handy, and I think Otieno had mentioned the discussions that are going on right now between NASCOP and some of these pharmacists. Already that identification has been done. There are pharmacies that have already been identified, of course, with the guidance of the commodity team at NASCOP. And I think once all is set, we should be able to then officially communicate and let you know some of the pharmacists that have been identified from the national level. So yeah, so thank you very much. Thank you very much, Otieno, and thank you very much, Rajab, for taking us through the demo. So I think we can open it up for any quick questions. I'm not sure whether there are any. Let me just go through the chat to see whether there are any questions. I'd requested that we can post our questions in the chat. Yes, so let me just allow me a minute to go through. Yeah, thanks, Otieno. I think you've shared some documents there. Yeah, Daniel had requested you to post the manage module PowerPoint on YouTube. I think, Otieno, you'll be able to do that. So there's a question from Augustine between the hub and the spoke, who is supposed to fill the community pharmacy model screening form. I think the other one is from Joseph Nyoden. Great work. Thank you, Joseph, for the compliment. Yeah, so I think that's the only question so far I can see, and maybe Rajab, you could respond to Augustine's question.
Yeah, thanks, Sangok. So for the screening form, as I had explained there in detail, this is supposed to be filled in the spoke facility where the client is going to pick drugs. So that's where this form is documented. Thank you.
Thank you, Rajab, for the response. I think you had already responded on the chat, but I think it's also good to just verbalize it for purposes of clarity. That's fine. So I don't know whether there's anyone who has a question. You can raise your hand, and we'll allow you, give you the mic to verbalize. Just in case you have any question, or you probably have a comment, or there's an area that wasn't clear, and you probably want some more clarifications on. You can raise your hand. We'll give you the mic. Because so far I'm not seeing any other question on the chat, so maybe we can switch to taking your questions just in case there's any. So I'm not seeing any hand up. All right, so Duncan Obunge, so Otieno, you can allow Duncan to ask his question. You can give him the mic.
Yeah, Duncan has the mic. You can
All right,
unmute.
Duncan, go ahead. Duncan, unmute and go ahead. So meanwhile, there's a question from Dennis. As Duncan is unmuting, I don't know whether
Can you hear me?
Oh yeah, go ahead.
Okay. So thank you, Songok, for the opportunity and of course just convening us together for this presentation. And thank you, Otieno and Rajab, of course, the entire Palladium team for the good work towards just ensuring that the module is up and running. My major question is in regards to, it seems like the community pharmacy is, for me, the way I perceive it is like giving us a scenario of a multi-tenancy kind of approach where we have a central server, which will be like the hub, and then we have like the spokes, the other, the pharmacies where the patients are able to pick the drugs. If that's the case, then does it mean that can we also just try and do the same with we say that we have a facility which has we have the same be mirrored for a facility where we have the hub and the spokes. So all facilities riding on one server or accessing one server or utilizing one server. The concept of multi-tenancy.
Right. Thank you, Duncan. I think I understand your question, and I hope Otieno and Rajab have both understood, because I know most of our sites, the servers are localized. I know this would work best if we were cloud, but maybe Otieno and Rajab will respond to that. Before Rajab, you go, I think there was also a question from Adil Betty. Betty is asking, is there a fee to be paid if a client goes to pick drugs at the spoke pharmacy? I think the rest are comments. Maybe you could respond to the yeah. Then there's another one from Susan. Where will the community pharmacy be getting the drugs from? So maybe you can respond to those three. Otieno and Rajat, you can choose who goes first. Rajat, you can go first.
Thanks, Sangok. So I think I'll start by responding to Obunge's question. So so the way the pharmacy model has been set up ideally is we are using the same facility, which is called which is the MFL code from the same facility. What we're just doing is just adding locations that we call the dispensing locations, so that these clients can be able to get drugs from the other sites. In terms of multi-tenancy, I believe it's still some work in progress. As you know, for multi-tenancy, we need to have all these sites mapped to their different MFL codes, so that at the end of the day, when you're doing your reports, you can just pick data from a particular site and not the entire hub as is right now. So I think the model that we're currently using for community pharmacy is not more of like a multi-tenancy, but is just adding locations for dispensing. Yeah. Hope I've been able to answer your Bunge on that. So the next question, I think, is from Susan, where they're asking where the pharmacies will be getting drugs from. Yeah, so the pharmacy will be getting drugs from the hub location, which is the actual facility. So they'll be doing requests to the hub, and then they'll be issued with those drugs from the hub. Yeah. I think if there's one that I've left out, maybe Otieno can respond to that.
Okay. Thank you, Rajat. So I think the process of requesting and of course the sourcing for drugs doesn't change. So the hub site would be more like can I call it? Allow me to just call it central site for now. And the spoke site will be more like more like satellite site. So they'll be receiving their drugs. Just to amplify on what Rajat was saying, they'll be receiving the spoke site will receive drugs from the hub site, the hub sites, which basically are more like the central site. So these are sites to receive their commodities directly directly from KEMSA. And that's the procedure right now. I think so. So nothing really changes. Otieno, do you have any additions? Meanwhile, as I go through the chats, Otieno, any other comment?
No, I think Rajab has responded to I think almost all the questions that were up there. I don't have anything to add.
All right, thank you. So Daniel Maritim is asking, so those does it mean that the hub facility should be running cloud-based EMR to allow pharmacists to update the records from there? I don't think that's the case right now, but maybe Rajab, you could repeat, because I think this is just related to what Duncan had asked earlier. Rajab,
Thanks,
maybe you could, yeah.
Thanks, Songok. So maybe just to answer Maritim. So ideally all the other facilities need to have access to the hub through a network. So this can be done maybe through yes. So the best scenario is if you're using a cloud-based KenyaEMR, that will be easy. But if you're using a localized instance, then we need to provide that server with internet and basically have some VPN in place so that the spokes facilities can be able to access that particular hub securely to prevent any data breaches. Yeah.
All right, thank you, Raja. Yeah, so I think I'd already alluded to the steps. It doesn't have to be cloud EMR, but then again, there has to be some sort of a means of getting in touch, or accessing the instance at the facility level. So I think Raja, if expanded on that, just probably not operating on cloud, then you need some sort of connectivity, meaning if you're using a gadget like a tablet in the pharmacy or in the community, then it means you must be able to access the instance at the facility level. So thank you very much. Sorry. Yeah, so I think most of the other questions have been responded to. Some are comments. We appreciate some of those comments. Otieno, I think you've also been able to. Okay, let me see. There's one from Jeffrey here. Rajab, I don't know. Is this particular model also available for the KVP site? Because I think Geoffrey is asking a question in reference to a drop-in center. So maybe you can just make a comment on that, Rajab, more specifically for the drop-in centers for KVPs.
Thank you, Sangok. Yes, this should be able to support, as I believe all of these dices have been mapped to KenyaEMR. Basically, they have an MFL code, and they can be added as the dispensing locations mapped to the main hub, and they should be able to work. Yeah. Over.
Thank you. So, Geoffrey, there you go. It's possible. So you can also be able to utilize this particular model. All right, so I think I will then close it there. I know we are slightly past.
Sangok, I don't know if, sorry. There was a question from Betty. I don't know if you were able to guide. There was a question around the cost. Is there a fee to be paid if a client goes to pick drugs at the spoke? So maybe I thought she could be guided on that.
Oh, okay. Yeah. Sorry, I think we almost, I think I've seen. Yeah, so for now, Betty, there are no costs. Maybe what would be required is depending on where the spoke is situated, maybe a cattle transport to get to the site. But I think for now, the service will be free. I know there was a concern at some point, and I think I was in some of the discussions that I was in one of the meetings that this discussion came up in situations where some of probably the private chemists or the private pharmacies to charge a fee for services rendered. But I think the sites or the pharmacies that have been identified as it is right now will be able to provide this service free of charge. So there are no charges for now. But of course, in time, probably if anything changes, we'll be able to discuss and probably communicate appropriately. Yeah. So yeah, thanks Otieno for pointing that out. I think we almost it almost skipped our minds. Thank you. All right. So having said that, allow me to close this meeting at this point. And allow me to take this opportunity to appreciate everyone. Of course, the NASCOP team led by Dr. Lulu, who is our side lead. The Palladium team led by Dr. Jacob, who is the project director, and all the stakeholders who participated in ensuring that this is realized. The main agenda as to why we do this, or the main objective, is just to enable to capacity build you, and so that you are able to utilize this particular product that we keep developing over time. Make your work easy at the facility level. Someone had asked, is this like the final one? But we'll definitely have more engagements on the same. Just talking about or just taking you through some of these products, and more importantly, you know very well that we always have service desk, a toll-free number where if you have any issues, you can always reach out, and I'll request Otieno to just repost the toll-free number, the service desk number, where whenever you have any challenges, you can reach out. But we'll organize more of this training. Whenever there's an opportunity, of course, some of our colleagues will be visiting some of the facilities to provide more TA and more support, physical support. But then again, you appreciate the fact that we may not be able to reach out to everyone because of lack of resources. So we always try as much as we can to use this option in terms of widening our reach and the capacity of our service providers. So at this point, but I don't know that Diana was able to join because we need to close. And if Diana didn't join, I want to allow Otieno to just make one or two comments and then we close. Otieno, over to you.
Yeah, thank you very much, Songo, for the opportunity, and thanks everyone who has found time to really join this training. We were worried when we started that we are not going to have a quorum, and I think we've managed to have a quorum of about 271 participants. So I think that's very good. We are continuing with the virtual training series just to build your capacity on different aspects of HIS solutions that we support. So the trainings will continue. So the next training was supposed to have been next week on Thursday, but we are having some activities next week that may not allow us to conduct a training. So the next virtual training will happen on 19th, that is the Thursday after next. And our topic for that day will be about billing and how we do the billing processing, the bill payment, the waivers and all in the facility-wide EMR platform. So look out for that on 19th of September. Otherwise, I think we have had a session, and I wish you all the best for the remainder of the day. Thanks, and back to you, Songok.
Thank you. Thank you very much, Otieno. And I think from my end and on behalf of the leadership at NESCOP, let me also just take this opportunity to appreciate you all for creating time to be with us this Thursday. We are looking forward to more engagements and of course, more of such. Otieno, thanks for reminding us about the upcoming training sessions. And you've clearly indicated because of other engagement next week, we'll not be having the training. So I think we'll end it there. Thank you very much. Enjoy your evening. See you in 2 weeks' time for another session. Thank you and bye.